These are all valuable and valid reasons why one brings something new into the practice. So let's look a little bit at one of my more recent pain points, and it was really getting more predictable restorative dentistry, especially in these more complex cases that come into your door. You know, a case like this that comes in that wants you to replace the broken crown on the abutment on number 15. This looks totally easy to do. And quite frankly, had I not had a digital scanner, I don't know that I would have appreciated it as quickly. I'm pretty sure I would have taken the impression, sent it off to the lab, and gotten the phone call that I didn't have enough space. The benefits far in my clinical world have far exceeded some of the challenges that you run into. Patients adore it and love it. They hate dentistry in general. Any opportunity to make it just slightly more comfortable or just frankly slightly more cool seems to really resonate with their experience. We as clinicians get immediate feedback on the quality of our preparation, quality of our marginal isolation, reduction of clearance. All of those things are really important, and we can go back in and recapture information very easily and quickly. We get a little air bubble, this isn't going to be a whole nother 5-8 minute process of retaking a PVS impression. So let's go through some of the applications that we're currently using in our office when it comes to intraoral scanning. The one most of us think about is, you know, we buy these intraoral scanners as a fancy replacement for a PVS impression machine. I would argue to you that they need to be doing a lot more in your practice than just taking an impression in order to really maximize your investment and value. But let's just say, for the sake of argument here, that you just want to replace your PVS operations and your alginate operations in the office. So we're going to use it for indirect restorations and what we maybe mill in-house or send out. Certainly, they are predictable at getting good, accurate scans and marginal visualization to get good deliverables. You know, those are cases that I have done where I can say I'm very content with the marginal quality of what we receive from the laboratory fabrication of the digital impressions that we were able to provide to them. We are also using it for our own in-house, full coverage and veneering restoration. So, you know, I can use different scanners to do my milled restorations. And again, I'm content. I'm very happy with the way those margins look compared to old PVS or EMAX restorations that I was making off of, PFM crowns that I was making off of PVS impression materials, 10 years ago. So here's a clinical case, old composite restoration. We've got some fracturing. There's recurrent decay present underneath. So we're going to go ahead and do the preparation of the crown. We're going to do an adhesive technique to do the deliverable here. And really most of the margin, which I try to do as much as I can, is a super gingival presentation, but I still got this deep distal margin. Now, old me 15 years ago probably would have pulled out the diode and just stroked right through that. New me likes to pull out X-Facil and get some retraction in that space. And I continue to be amazed at how well it manages tissue retraction and pushing and opening that sulcular space. But in addition, the heat and the fluid that wants to flow up into that space and impact your ability to take a solid scan. So now we can get a nice clear read on the scan. We can see the margin all the way around, and look at that that separation and distance that you see down on that distal margin. It's incredibly visible to me, exactly where I need to draw my margin. And this is the deliverable we were able to give to the patient before we cemented it in. And that is an accurate read of that distal margin using just retraction paste alone. So in addition to indirect restorative applications and getting that really good marginal read, we're going to use intraoral scanning for direct application. I know a lot of people don't think about that, but in our practice, I'm actually doing a lot of intraoral scanning for my chairside veneer cases, or if I want to make a Pontic to fill in an empty space for a patient, I can do an intraoral scan, design it in exocad, print it on a 3D digital model, do an injection mold technique, and get that for the patient in a very short turnaround, like in that case for prom. I'm also using intraoral scanning for implant application. Certainly, you can use it to scan for single unit restorations, to do custom abutments and crowns, but I'm also using it a fair amount in my implant surgery cases. I don't place my own implants, but I like to help guide and direct how my surgeons are going to do that, especially for these all-on-4 or overdenture cases. So we need to start with the intraoral scan to capture as much of the dentition as we're hopefully given, and overlay that with the CBCT and start to pre-plan for those surgical guides so that we get those implants in the most ideal restoratively driven location. Same here for even single tooth, pre-planning it in a software so you can build your surgical guide and actually do an immediate predictable implant on tooth number 30 in the interceptal bone. Would never do that without an intraoral scanner and CBCT technology. In our practice, we're also using intraoral scanning for appliances. So this is the sleep appliance we're going to fabricate for the patient. You can capture an open bite with most scanners and be able to have the laboratory set that articulation exactly where you have designed it to be. But the pro tip is that most scanners need to see cusp tips in order to be able to capture the bite. So I will often put some type of anterior jig in place. Maybe that's your George's gauge. Maybe that's the airway metrics system, if you happen to use that, or a deprogrammer. Build in your bite registration in between the arches. Trim that bite registration back so you see the cusps all the way. And your intraoral scanner will just scan the teeth and cut out the bite registration, or at least the one I use does that. Check with your manufacturer to make sure. But the key point is that it needs to see the cusp tips in order to be able to accept or agree with the bite that you're giving it. Really looking at opportunities for your intraoral scanner to educate patients. Look, in one intraoral scan that takes less than 5 minutes for my team members to accomplish, I can highlight abfraction, recession, erosion, super eruption, attrition, malocclusion, crowding, all kinds of crazy stuff that we would have to take 1,000 different intraoral images and take some impressions, then pour it up and have some type of conversation about that. I'm able to capture an incredible amount of information in a very short period of time.